Radiation therapy is also a cornerstone of treatment for cancer. It's one of the oldest non-surgical methods for cancer treatment, and about 50% of all cancer patients will receive some radiation at some point in their treatment. It's very important that they measure the amount of radiation that a person gets. This is even for X-ray techs, radiologists. Radiologists actually have an increased risk of getting cancer due to radiation exposure in the X-ray department. But what they do is they take the radiation dose and they divide it into fractions, and it just depends on the treatment regimen, depending on what type of cancer it is. For example, my husband had only radiation 5 days a week for 20 weeks. 4 weeks. He had 20 radiation treatments. So it just depends on the person and the mass and all of that stuff. So, and also they determine the strength and the dose and the number of the doses by tumor sizing and staging. So cancer is low energy beams. They can penetrate a very short distance, useful for skin lesions. High energy beams, they need a greater depth of penetration, and looking at optimal dosing of the internal targets, but sparing the outer skin. I think you can read that. You can read those. Brachytherapy, this is when they implant or insert radioactive materials into or close to the tumor. Some of these types of things may be like putting seeds in the prostate, or putting seeds into the bladder to treat that kind of cancer. And so for that, we need to be careful that we are protecting ourselves from the exposure from that person. But it also is good because there's minimal exposure to healthy tissue, and it's usually used in combination with external. Oops. I missed one. Okay, we'll go to this one. So common side effects for chemo and radiation, as I talked about before, bone marrow suppression is really important. That will limit the dose. It may even stop the treatment for a while until it gets better. Fatigue, and remember that is inability to rest or inability to feel rested even after they were able to rest. GI disturbances are a big problem, nausea, vomiting, diarrhea, also stomatitis, mucositis, which makes it very difficult for them to want to eat and to be able to physically eat something. Pulmonary effects, some radiation can cause some long-term effects. If somebody gets radiation to their lung, a lot of times we see that they have pleural effusions later on after their treatment is done because it has affected those tissues, and they get a lot of fluid built up in the pleural space, and they have to have a pleurocentesis for that. Reproductive effects, we talked about that. Knowing that if they're young and they want to bank their sperm or bank their eggs, then we need to offer that to them. Myelosuppression, most common side effect of chemo, is where the RBCs and the white blood cells are low, which puts the patient at risk for infection, for hemorrhage, and overwhelming fatigue. If we don't have red blood cells, we're going to have a reduced ability to carry oxygen. So neutropenia, which is low neutrophil white count, is the most common in patients who receive chemotherapy. We also need to encourage them to do exercises and activity within limits that they can tolerate every day, just to try to keep their strength up. For GI effects, prophylactic administration of antiemetics, as I said yesterday, Zofran, Phenergan, Compazine, all of those things can be ordered, and most likely are ordered around the clock, so they get better control of that. Also decreasing fluids when the patient is nauseous and vomiting. Assessing for signs and symptoms of alkalosis, dehydration, and INO. Encouraging them to have a low fiber, high calorie, high protein diet. And again, 6 small meals a day. Other problems with the GI tract, diarrhea, those medications, antispasmodics such as Bentyl is a good medication that will calm down their GI system. Anorexia, we need to monitor them carefully, what their weight loss is. The dietitian can come in and measure, do their anthropotic, I can't think of that word, where they measure your skin folds and see, how thin you are and how cachectic you are and that kind of stuff. Again, the small meals and encouraging nutritional supplements. There are also saliva substitutes that we can use for them, which are really gross. But if they're not able to drink water, if their mouth is super dry, this would be helpful for them. Skin reactions are one of the biggest problems that happen with radiation treatment. It can be acute or chronic, and it can develop anytime during their treatment within 1 hour to 24 hours. They get an erythema to their skin. They get dry, they get a pruritus, which is itching. Things we can do about that is to make sure that we lubricate their skin with like hypoallergenic stuff that is not perfumed and really smelly and will be irritating. No alcohol or perfumes in the lotions. That's helpful. Also, we need to prevent infection when this happens, because your skin is your largest organ, and anytime there is a break in the skin, that is an opportunity for infection. These patients don't have the reserve that everyone else does, with no white blood cells, low neutrophils, to fight any kind of infection off. So we need to be sure that we are turning these patients and turning them with pillows and propping up areas of skin, using other things such as heel protectors, elbow protectors, pillows, things to make sure that their skin is not breaking down. Pulmonary effects, cough, dyspnea, pneumonitis, and they can also get pulmonary edema. Both chemotherapy and radiation have the potential to produce pulmonary tissue damage that is irreversible and progressive. And it may be alarming to the patient, because these effects sort of are the same symptoms if they have lung cancer as they had before, would be the dry cough and the shortness of breath. So they may need encouragement and taught that this is something that is expected and not a return of their cancer. Some patients also are left with pulmonary fibrosis that makes the lung very rigid, and it's very difficult for them to have good air inflow and out. So bronchodilators could help that, like albuterol, are the ones that we know, expectorants and cough suppressants, bed rest, oxygen, and of course plenty of water if they tolerate it. All right, I skipped one. I can't get it to go back. So this was cardiovascular effects, the slide that I missed. People who have pre-existing coronary artery disease, of course, are more vulnerable. Radiation-induced heart disease is more likely in patients given high doses of radiation. Commonly will cause a pericardial effusion, which is that sac, the outer sac of the heart, that can hold 5 to 20 milliliters of fluid. With a pericardial effusion, it can actually go up and hold up to like a 2 liter of Pepsi in there, which decreases their cardiac output, causes that leathery pericardial rub that we can hear. Reproductive effects, we've talked about that one. If particularly for the males and the female nurses, we need to be sure that we are staying behind the shield and organizing our care, that we're not in and out, because every time we go in there, we're exposed maybe to a little bit of radiation, and there's only X amount of radiation that any of us can be exposed to in our lifetime. So coping, assist with planning. As the nurse, you do play a key role in assisting patients to cope with their emotional issues associated with having cancer and receiving treatment. So just being there, being present, not always talking, but maybe just passively listening, That's the best thing, just to be present at the bedside for the patient. And also encourage them to express their fears with you, build that trusting relationship so they can feel that they can tell you how they're feeling. And, we can't raise false hope, but we can't also, kill their soul. We need to be able to find a balance in there where they get some comfort and learn ways to decrease their own anxiety. And that may be through distraction, it might be through guided imagery, it may just be doing abdominal breathing. Very deep abdominal breathing will also reduce anxiety levels. Okay, I'm going to pass that one. Okay, skipped another one. This was about malnutrition. They get fat and muscle depletion when the body is not able to have its nutrition. The body will break down its own muscle to get the protein, and they'll break down fat and muscle, and that will leave them sometimes with a ketosis. That comes from anaerobic metabolism, and they get some lactic acidosis going on with that. They usually experience malnutrition, protein nutrient deficiencies, electrolyte depletion, dehydration, weight loss, and because they don't have good protein stores, they have impaired wound healing. So we need to offer a soft, non-irritating, high protein, high calorie foods throughout the day. Also encourage those nutritional shakes. Avoid extremes of temperature, as well as tobacco, alcohol, spicy, rough foods, things like that. Once a 10-pound weight loss occurs, it is very difficult to maintain their nutritional status. And this could happen very quickly if they're not eating for 3, 5, 7 days. We need to monitor their albumin and their prealbumin levels. Those are serum. And encourage enteral or maybe parenteral nutrition. Maybe they need an NG tube with some tube feedings, or maybe they're going to go all in and get the PEG tube, and we could give them nutritional supplementation that way. Complication of cancer infection is one of the most common. These occur due to ulcerations of the skin, of the mouth, compression of vital organs by the tumor, and the neutropenia that occurs. So we need to instruct outpatients and our patient care techs who are taking our vitals that we need to they need to notify us or the healthcare provider if the temp is greater than 100.5, because that is really a baseline definition of having a fever, a low-grade fever. And we also need to look for signs, like insidious signs of infection, like maybe a sinusitis, a respiratory infection, a UTI, things like that. Okay, so for that. So back to this one, primary cause of death. Usual sites of infection are going to be the lungs. Pneumonia is very difficult to combat when you have low protein stores and your body is immunocompromised and suppressed. The GU system, of course, that would be, we're looking for a urinary tract infection or a kidney infection. Infections of the mouth or the rectum, those can be, candidiasis, something like that, that's breaking down the skin. Infection in the peritoneal cavity, and also very common infection in the blood, because remember, these patients have central venous access devices, and it's just a really high risk of having infection related to that. Okay, there's some oncologic emergencies these are life-threatening, resulting from the cancer itself or from the treatment, and these are classified as obstructive, metabolic, and infiltrative. These commonly include something that is called superior vena cava syndrome, where they get a large clot in the subclavian vein right underneath the clavicle. Spinal cord compression. They can also get SIADH, which is syndrome of inappropriate antidiuretic hormone secretion. Problems with hypercalcemia, tumor lysis syndrome, DIC, which is disseminated intravascular coagulopathy, and also cardiac tamponade. And here's the superior vena cava syndrome. As I said, it's an obstruction by the tumor or a thrombosis. We're going to see signs. There's going to be edema in that clavicle area. Facial and periorbital edema is very common. Also distension of the veins in the head and the neck and the chest. Patients may develop seizures and may also report a headache. Spinal cord compression happens when the tumor invades the epidural space. Some of these signs, the signs and symptoms are listed here. Most common cancers that cause this problem are breast, lung, prostate, GI, and renal tumors. The use of radiation in conjunction with corticosteroids is generally associated with some initial improvement. Sometimes they have to do a laminectomy to decompress that area in surgery when the tumors are not responsive to radiation. This really limits activity, and pain management is a real important thing for nurses to do. I did care for a person one time who had this, and he was just, I don't remember why he had it, but I think he was a weightlifter, but he had all of these classic symptoms. The next obstructive emergency is third spacing syndrome. This is when fluid shifts from the vascular space to the interstitium. And this generally occurs as a result of extensive surgical procedures, or it could be because of septic shock. These are, the signs of hypovolemia. They're listed here. Treatment, of course, is to replace their fluids, electrolytes, and plasma protein. So plasma protein would be, they might get 1, 2, 3, 4 doses of albumin, which is a blood product. So it does require a blood transfusion consent form in order to give that. So, but while we're recovering them and replacing their fluids, we also need to be watching for hypovolemia, because as we give them albumin, albumin's job is to pull that fluid out of the interstitium and back into the cell and back into the vessel. So they could actually get some signs of hypervolemia, which would be hypertension, elevated CVP, JVD, weight gain, and shortness of breath. SIADH occurs, and it is an emergency caused by production of ectopic hormones. And these ectopic hormones come directly from the tumor and are secondary to metabolic alterations caused by the presence of the tumor or cancer. These hormones arise from tissues that do not normally produce these hormones. Cancer cells return to a more embryonic form or a stem cell, thus allowing the stored potential of the cells to become evident. Patients will also, we're moving on to that, hold on a second. All right, so there is, SIADH is a syndrome that results from an abnormal or sustained production of ADH by the tumor cells, so which results in water retention and hyponatremia. So it's a relative hyponatremia, because they're really floating in so much water, we don't know truly what their sodium level is, but the body doesn't know that, so they still present with symptoms. SIADH occurs most frequently in carcinoma of the lung, but also can happen in other cancers in the GI tract, pancreas, duodenum, brain, esophagus, and so forth. Symptoms include weight gain without edema, weakness, nausea and vomiting. Personality changes has to do with the sodium and the CNS. They also can have seizures because, again, the body only knows that the sodium is low. It doesn't know why it's low. So hyponatremia can put the patient at risk for seizures. Oliguria, and they can actually go into a coma. Treatment is treating the underlying malignancy first, and we got to correct the sodium and water imbalance. So we do this with fluid restrictions. They will also order them salt tablets around the clock, and we can give them isotonic or 0.9% saline. Some cases that are severe, we would give 3% saline IV, which is a hypertonic solution. Sometimes they'll use Lasix, furosemide, in the initial phases just to help get rid of the fluid. And we really need to monitor the serum sodium levels, and sometimes they'll also monitor the urine-specific gravity to guide their treatment. Hypercalcemia results from secretion of the parathyroid hormone, and this occurs in approximately 10 to 20% of patients with advanced cancer, usually with lung cancer, cancer of the head and neck, cervical, esophageal, lymphomas, and leukemia. Because the patients are very ill, sometimes they're immobile, and coupling that with maybe some dehydration, that will exacerbate the symptoms. So we're going to have a hypercalcemia that, again, is relative. Not enough volume, not moving around, calcium's moving out of the bone into the blood, so we're still going to have hypercalcemia. We can see serum calcium levels in excess of 12 milligrams per deciliter, which will often produce symptoms and can be life-threatening. The long-term treatment of hypercalcemia is aimed at the primary disease. We can also treat with hydration up to 3 liters a day, just to dilute the blood, and also bisphosphonate therapy, some of those menopausal medications such as Zevista. I can't think of any more right now, but those things that we do for calcium levels. So tumor lysis syndrome is nasty, triggered by the chemotherapy's rapid destruction of a large number of tumor cells, also normal cells, remember. So if you remember, the serum phosphate and calcium have an inverse relationship. So serum phosphate will go up, resulting in the calcium going down. This can put the patient into renal failure, and as I said, it can also be fatal. It occurs less commonly in patients receiving radiation. TLS, as it's called, is often associated with tumors that have a high growth rate, but are sensitive to the effects of chemo. The primary goal of TLS is preventing renal failure and managing electrolyte imbalances. There are 4 hallmark signs of TLS, and they are hyperuricemia, hyperphosphatemia, hyperkalemia, and hypocalcemia. Early symptoms for these electrolyte imbalances: weakness, muscle cramps, diarrhea, nausea, and vomiting. The primary treatment includes increasing their urine production with hydration and decreasing uric acid concentrations using allopurinol, which allopurinol is a medication that reduces serum uric acid levels in patients who have gout. So other oncologic emergencies, anybody can get any of these, but cancer patients and receiving chemotherapy are at a higher risk. Septic shock, DIC, and other infiltrative emergencies, such as when the malignant tumors infiltrates into the major organs and causes more problems. Don't go too deep with that septic shock and DIC. So cancer pain, we must always believe the patient, as usual, if they're telling us they're in pain, and we need to do pain assessments. And we need to be on top of that. We need to remember what it feels like to be in pain and to be vulnerable as a patient in the hospital, and either not to be believed or to be under-medicated when it's just not necessary. Moderate to severe pain occurs in approximately 50% of patients who are receiving active treatment for their cancer, of course. And we really should be using different kinds of pain scales, right? The Likert scale, from 0 to 10, 0 being no pain, 10 being the worst pain ever. We can also use FLAC for children, which are faces, and we can also have them point to pictures, both adults and children. Under treatment of pain, it causes needless suffering. It decreases their quality of life. It makes them not want to do anything, not want to move, get up, go outside, get in the sunshine, any of those things. So, and it puts an increased burden on the family because it's very difficult to watch your family member be in pain. So an inadequate pain assessment is the single greatest barrier to nurses managing pain. Fear of addiction is unwarranted in these patients. They may be terminal, which is not going to make any difference. Or we also need to let them know that, although we can't guarantee that, Addiction is always a possibility, but not likely. They're really doing a better job about reducing doses and not giving people as much pain meds as they had in the past. There are a lot of other things that we can do, which is not necessarily opioids. We can use non-steroidals like Motrin, aspirin, Tylenol, those things. We also need to teach the patient for sure to let us know and let their family members know when their pain starts to return. When the pain is low, we can manage it much easier than if they wait too long and it gets to be so much. At that point, we may have nothing that we can give them that will make their pain go away. So we need to discuss the goals of pain therapy with the patient and honor their wishes and what they want to do, but they need to make an educated decision about pain medicine. Psychological support, we're going to focus on quality of life, positive attitude of the family and patient, and also the nursing staff, goes a long way with helping the patient cope with what they're going through. Common fears, of course, everyone's afraid of disfigurement. If you've ever seen anybody that has had a radical neck because of oral cancer, that is a really significant surgery. Also emaciation, losing tons of weight, not looking like themselves, having color changes, being sallow, yellow. They could be, I can't think of the word, when they get the liver and the orange, that word is escaping me, when they get that cirrhosis. Also fear of dependency, which we can help them with that. Disruption in relationships, too much pain, concerns about their finances, concerns that they will be abandoned, and also concerns about death. So coping with cancer, again, assessing the psychosocial concerns and the emotional responses of the patients and the family so you can connect with them and build, a bonding relationship. We can also get social services on board, case management to help with financial burden, application for charity care, whatever, and also paying attention to their religious, spiritual, and their cultural beliefs. We need to be aware of those things and provide those. All right, I think you can read that. You can read that.